Are you seeing my slide now?
Uh, yes.
Okay, good. Okay, description. You can see the epiglottitis changes on this lateral neck X-ray, and this for the CT scan, we are seeing the epiglottis is also thickened with presence of air locules within. So this is an example of acute epiglottitis secondary to gas-forming organisms. So for treatment of epiglottitis, usually we do direct laryngoscopy and intubation in control setting. And we administer, the clinician will administer broad spectrum antibiotics and give steroids for supportive management. Next on, we move on to croup, which is acute laryngotracheobronchitis. It is a viral infection of the upper airway by parainfluenza virus or RSV, most commonly between 6 months to 3 years old. Symptoms include protracted barking cough and inspiratory stridor, and this is due to mucosal edema resulting in tracheal narrowing. And the diagnosis is usually made clinical. But when we do imaging, this is what we are seeing. This is called the stipple sign. We can see there is supraglottic airway narrowing, which gives rise to this stipple appearance, or we can call it inverted V sign. The epiglottis here is normal, but the subglottic region here is narrowed. So this is an example of acute of croup. So we are done with the first part. We move on to the next part, the deep neck spaces, abscesses. We go to the, first of all, we go to the retropharynx. So retropharyngeal infections, etiology, most commonly when we see retropharyngeal infection or collection, it is due to penetrating trauma due to foreign body, most commonly fishbone. Sometimes separative retropharyngeal lymph node from pharyngitis and tonsillitis causes infection in the retropharynx, or sometimes it could be due to adjacent ascites or osteomyelitis. What happened in foreign body ingestion is that there will be perforation of the hypopharyngeal wall, causing a retropharyngeal abscess formation. For infection of the pharynx or the tonsils, what happens is that these sites are the primary drainage path to the lymph nodes in the retropharyngeal space. So when it is inadequately treated, these retropharyngeal nodes becomes enlarged and may rupture and form retropharyngeal abscess. So patient symptoms varies. The patient could present with fever, sore throat, neck pain, and limited range of motion. This is an example of acute separative retropharyngeal lymphadenopathy. We can see the node in the left retropharyngeal region here is enlarged and necrotic, and we can see inflammatory changes in the nasopharynx here. We can see the adenoid is enlarged, as I mentioned earlier, this serpentine hyperdensity type of enhancement, which shows the normal adenoid hypertrophy, which is inflamed. So if, let's say, this node is untreated and it ruptures, it will form into this. Here we can see there is a hypodense rim enhancing collection in the retropharyngeal region here with marked surrounding inflammatory change. So whenever we see this, don't forget to image the carina and the don't forget to image up down until the carina, because of the potential space posterior to the retropharyngeal space, which is called the danger space. So danger space is this space, this green space here. It is posterior to the retropharyngeal space, posterior to the alar fascia. So when we do imaging, we cannot really see this space. Sometimes we can demonstrate this alar fascia, but most of the time we do not. So so whenever we see retropharyngeal abscess or collection, we just extend down the CT scan until the mediastinum, till the carina, to look out for the possible spread of infection through the danger space. Descending necrotizing mediastinitis is one of the complications. Mortality rate is quite high, up to 40%. So what happens is that the spread of infection is through the danger space or the carotid space. So CT findings of acute mediastinitis include mediastinal fluid collections that could have mediastinal fat stranding, air pockets, pericardial or pleural effusion. Management will be airway protection, antibiotics again, sometimes surgery if the infection is too bad. Multiple for this CT scan, it shows multiple air pockets at the retropharyngeal space here, and as well as at the surrounding visceral space in the neck region. So as they extend the CT scan, the imaging down towards the carina, you can see the epicus extend all the way down to the mediastinum. So this is an example of case of acute necrotizing mediastinitis. What about parapharyngeal space? Parapharyngeal space, I think everyone is very familiar. So parapharyngeal space, any infection of the neck could has potential spread to the parapharyngeal space. So it's like a highway. So anyone can, any infection, for example, acute tonsillitis, peritonsillar abscess, or rotogenic infection, anywhere in the head and neck has a potential route of spread to the parapharyngeal space. So the symptoms is variable. The patient could present with the initial, the origin of the infection site. But clinically, the patient will show progression, for example, upper airway or alimentary tract obstruction. Complications is there are variable complications from parapharyngeal abscesses, which could be edema of the larynx causing airway obstruction. It can result in Lemierre syndrome, which I will talk later. Again, it can spread to retropharyngeal space. It can spread to the mediastinum. It can cause mycotic aneurysm, causing this carotid blowout and hemorrhage. Yeah, so whenever we have a CT, it's good that we have two sides of the neck, the left and right. So this is the normal right parapharyngeal space, and this is the abnormal one. We can see the collection there and the surrounding inflammatory changes of the adjacent pharyngeal wall and the muscles and the prevertebral muscles here. Vascular space, we have this Lemierre syndrome in which there is septic thrombophlebitis of the IJV causing disseminated abscesses and septic pulmonary emboli. What happened is that there will be preceding bacterial or pharyngeal infection, for example, pharyngitis or tonsillitis, which spreads to the lateral pharyngeal space. It can be seen in healthy adults or adolescents. Causative organism, this organism is quite famous when we talk about Lemierre syndrome. It is Fusobacterium mucoforum. Symptoms, patient will be unwell. So the resulting bacteremia and distal infected thromboembolism, we can see multiple septic emboli in the lungs. We can find lung abscesses, empyema. You can go to the CNS causing durovenous sinus thrombosis, meningitis. You can go to the joints causing septic arthritis. It can go to the liver even though it's rare. This is an example of a Lemierre syndrome. We can see a filling defect within the distended right IJV. The surrounding IJV wall is enhanced. And when we image the lung, we can see multiple septic emboli. So this is a classic example of a Lemierre syndrome. Next, we move on to the other organs. Oh my, I have 70%. Salivary glands, other organs, for example, salivary glands, orbits, lymph nodes, and yeah. First, we go to the salivary glands. We have salinitis, infection or inflammation of the salivary gland. Patient will present with salivary colic, which is painful swelling, which is exacerbated by eating. Etiology will be obstructive calculi, usually present in the submandibular duct in 80 to 90% of case. Sometimes and less commonly in the parotid duct. Most common causative organism will be Staph aureus. Why is it more common to occur in the submandibular duct? If you notice the anatomy, we can see that this Wharton duct or the submandibular duct has an ascending course when it drains into the floor of the mouth. In contrast, the parotid duct has a more horizontal course. So this mandibular duct tends to have stasis and develop stone. So salinitis, what we can see on CT is the submandibular gland will be enlarged and enhancing. There will be ductal dilatation, which could be due to calculus or stenosis. They can have cellulitis and myositis changes of the sublingual and submandibular spaces. Sometimes when we image oral cavity tumor, we can see the submandibular salinitis also because of the obstruction to the salivary duct. Here, the CT scan shows asymmetric enhancement and enlargement of the right submandibular gland. When we image further, we can see the submandibular duct is dilated with the presence of stones. So this is a classic case of right submandibular salinitis secondary to obstructive calculi within this salivary duct. This is a case which shows an enlarged, very enlarged right parotid gland as compared to the left with multiple hypodense collections within. So this is the surrounding subcutaneous fat is trending This is the case of acute separative parotitis, acute separative parotitis. So when we talk about parotitis, it could be bacterial or viral in origin. For bacterial, it is usually unilateral. If viral, it is bilateral. For bacterial, the causative organism usually is Staph aureus. If viral parotitis, mumps virus is the famous one. Bacterial parotitis is seen in elderly and debilitated patient. Viral parotitis is seen in young patient. What about orbit? So when we receive requests for orbit, usually the clinician want us to help them to differentiate whether it's pre-septal or post-septal cellulitis. So for us to be able to answer this question, what we have to know is this presence of orbital septum. So what is this orbital septum? It's a thin fibrous sheath which originates from the periorbita here, periorbital ostium, and it inserts into the levator pubital muscle superiorly, and the tarsal then inserts and it goes down here to the periosteum or the periorbital wall here. So anything anterior to this orbital septum, any infection which includes the ileus anterior to the orbicularis oris muscle is considered to be preseptal. And if the infection goes to the posterior to it, is considered a post-septal cellulitis. So again, on CT, this is how it appears. We do not really see this orbital septum on CT, but we can tell that this eyelid is at the anterior to the orbital septum, and anything posterior to this region is called post-septal orbital cellulitis. Again, differentiating periorbital and orbital cellulitis. Preorbital cellulitis, also known as preseptal cellulitis, is limited to soft tissue anterior to the orbital septum, usually contiguous parallel infection from the face, teeth, or ocular. And next, CT, we show thickening and enhancement anterior to the orbital septum, and management is usually antibiotics. For orbital cellulitis, it is a type of post-septal infection, usually seen from extension from PNS infection. What we can see is that there is post-septal thickening and enhancement. There will be complications, for example, superior orbital vein thrombosis, cavernous sinus thrombosis, meningitis, supraosteo or intracranial abscess. The difference in management is that for orbital cellulitis, they will give IV antibiotics and surgical drainage if there is presence of collection. So the image in the above shows a preseptal cellulitis, in which the preseptal tissue here shows diffuse thickening and enhancement and inflammatory changes. And this image at the bottom here shows a postseptal cellulitis, in which there is supraosteo reaction at the medial wall of the left orbit. The cryoadenitis is the inflammation of the lacrimal gland. Causative organism could be infective, or it could be inflammatory. On CT scan, it will be enlarged lacrimal glands at the superlateral aspect of the orbit. I think if I show the image is better, this is a position of this lacrimal gland. So when you see an enlarged and inflamed structure superlateral to the orbit, you are suspecting that could be arising from the lacrimal gland. The surrounding soft tissue is also inflamed. So this cryoadenitis is associated with preseptal cellulitis of the left orbit. What about dacryocystitis? So in dacryocystitis, what we can see is that there is a collection, or we say hypodense collection, at the region of the medial canthus here. So this is because of the lacrimal duct is obstructed, and the nasolacrimal sac is distended with fluid or collection. And usually it is associated with surrounding preseptal cellulitis. Infectious cervical lymphadenopathy is commonly encountered. So when we see this, we know that this is bilaterally enlarged necrotic cervical lymph nodes. For example, this one is caused by tuberculosis. We commonly see here in Malaysia, but it's not really common here. Yeah, so when we see this, I think it's quite straightforward. We can say that this is infective given the correct clinical setting and history. One thing that I would like to highlight is that whenever we are seeing intensely enhancing neck nodes, so for example, in this case, I'm sorry, this is in the bone window, but if you can make out these multiple enlarged cervical lymph nodes, is multilobulated, loss of normal morphology, and we should suspect of something else rather than just reactive nodes. We could suspect metastatic lesion from a primary hypervascular primaries. For example, in this case, we are seeing this mass at the left thyroid lobe, which could be possibly due to papillary thyroid carcinoma, causing hypervascular metastatic to the cervical nose. I have only 8%. Can I go to the quiz, Hope?
Okay.
Okay. Can I have someone volunteer?
I will ask for Raymond Tan.
Yeah, hi, Doctor. Morning. Raymond here. So
Very-
I'm provided. Hi, Doctor Hafiz. I'm provided with selected images of axial CT neck and also an image of uh, corona contrast enhanced. So what I can see here, there's periphery enhancing collection in the right overlying the right hemimandible. So it is associated with surrounding fasciitis and also and edema.
Yes,
Other
you got
than
it. You got that one right. So what about if I show you this one? What are you going to comment?
so, there's a periapical erosion of the right. This is right upper
Mandibular,
molar.
mandibular, lower.
Oh, lower. Sorry, right lower molar.
Yes, so how do you conclude this?
So this is odontogenic uh, odontogenic uh, abscess.
Yes. So it,
Yeah.
yes, correct. You did great. So you managed to identify that there is a submandibular collection, and you did try to find the source. So the source is odontogenic. So this is in case of odontogenic infection causing right submandibular collection here. Very good. Any? Yep. Yeah. Very good. Second candidate. You have only 1 minute.
Edward Lau. Edward.
Hi,
Edward,
Dr. Niva
you
here.
there?
Niva. Okay.
Yeah.
Okay,
So
Niva,
there
come on.
is
1 minute.
okay. There is irregular, ill-defined rim enhancing collection seen at the right peritonsillar region. In keeping with the right peritonsillar abscess, there is some narrowing of the oropharyngeal airway.
Yes, very good. You mentioned
and
everything that I want to hear. Very good,
a
Niva.
deviation of the uvula to the contralateral side.
Yes, okay, correct.
Otherwise, I do not see any other rim enhancing collections. The IJV, there's no thrombosis in there.
Yes, very good. Yeah, that is very complete. So this is a case of peritonsillar abscess. It causes narrowing of the oropharynx. Congratulations, Niva. Yeah, so this is another view showing the peritonsillar abscess pushing the palatine tonsil medially here. Okay, number 3.
Can I have Brian? Brian Pay.
Brian, 1 minute, Brian.
Hello? Can you hear
Yes,
me?
yes, we can hear you.
Okay, so the selected images of a contrast enhanced CT neck shows that there's a ill-defined rim enhancing multiloculated correction at the region of the right submandibular space. There's a medialization and narrowing of the airway. The
Brian,
adjacent,
Brian, sorry to interrupt you. What if
Yeah.
I tell you that this is actually Flatman?
Okay, so there's a ill-defined heterogeneously hypo-enhancing, heterogeneously enhancing mass at the region of the right submandibular gland. There's associated thickening of the platysma muscle and also the sternocleidomastoid muscle with surrounding fat stickiness at the subcutaneous region.
Yeah, so this is an inflammatory mass. So what do you think this is?
So, in summary, this may represent submandibular collection, possibly arising from the submandibular gland.
Okay, that is possible. But if we can see the inflammatory change, it goes to the flow of mouth. It causes narrowing of the airway. Any left-brain condition that you will think of?
So, and another differential that I'll consider is Ludwig angina.
Yes, correct. Okay, so correct. So the inflammation also involves the submandibular gland. That's why you cannot see. Actually, there's also cellulitis, but everything when you tie up together is actually cellulitis changes of the flow of the mouth, causing a compromise to the airway. So this is, compromise to the oropharynx. So this is an example case of Ludwig angina. Congrats, good try, Brian. This is on coronal view. Yep, you are right. You cannot see the submandibular gland. Absolutely correct. With the surrounding extensive inflammatory change. And yes, did you mention some odontogenic cause? I think he did just now. Yeah, so there is, so the potential cause is from the odontogenic also. Okay, this is quite straightforward. Anyone? Okay, never mind. I will just tell you this is an enlarged and enhancing right parotid gland. This is a just straightforward case of acute parotitis. But this one is not. We can see enhancing collection within the parotid gland. So this is a case of acute suppurative parotitis. This one, what I want to show is that, oh yeah, there's enhancing collection at the retropharyngeal space here. So this is an example case of a acute retropharyngeal abscess. May I know what do we need to image next? Any volunteer?
Extend the contrast to extend the imaging to thorax to look for
Absolutely.
assignment
Yes. Yes, correct. Because of which space is this?
danger space.
Yes, very good. Good. Yes, I feel very happy that you can answer all this. Yep. Correct. Retropharyngeal abscess, but this one they don't.
I think our presenter, Dr. Hafiz battery is empty. So since we still have some time, let me see. And I think our presenter is he is already offline. There is no battery on his laptop. Anyone has any questions? And before that, I would like to say thank you to Dr. Hafiz because of his effort to present on this informative acute hair and neck infection. I hope this presentation will be helpful for our daily work and to enhance our current knowledge.
Dr. Ho, Raymond here.
Yes.
Can I ask, how do
Yes.
we objectively differentiate peritonsillar and also intratonsillar abscess? And
Okay.
what would make the difference in the primary team
Okay.
management?
Okay. So from my personal opinion and from my knowledge, it's very rare to have tonsillar abscess. Most of the time, what you have seen, the abscess around the tonsils is mostly in peritonsillar. To have the tonsillar abscess is very rare because most of the abscess is in the crypts of the tonsil. So for the management wise, whenever I see abscess near the tonsil, I would rather say it's a peritonsillar. The management would be different because peritonsillar, they can extend to parapharyngeal space. And the drainage is not so straightforward. Okay. So to me, I won't really write tonsillar abscess. Most of the time it would be peritonsillar. Okay.
Okay, thank you, Doctor.
And nowadays, because the antibiotic is very useful, most of the abscess in peritonsillar, they don't really need to do a IND. Some of them, they can be tried with intravenous antibiotic first, rather than put a needle there in the peritonsillar abscess. Okay. Any
Okay,
more questions? Very good.
thank you, Dr. Ho. So I just contacted Dr. Hafiz. He said he's very
Yeah,
sorry
this
that
is.
so yeah, that's the end.
You want me to share some of the cases since we have time, or is it okay for us to end the session?
If you have cases, you can share. Lah.
Okay. So I just share my screen for a while. So I have some cases to share. Can you see my screen?
Yes, can see.
So this is a patient, 40 years old, with sore throat, dysphagia, and fever for 3 days. There are no history of trauma or foreign body injection. So can I ask any of the candidates to attend for this radiograph? Can I have Mayli? Tan Mayli?
Morning, can you hear?
Yes.
Okay. This cervical lateral radiograph shows that there is evidence of pre-vertebral thickening extending from around C2 to down to the C7 level. And there is also widening of, there is also narrowing of the upper larynx and thickening of the soft tissue seen here.
Okay. So usually what will you do? You will be proceed with CT neck from
Yes.
the front sinus to the carina, like what the Dr. Huff has presented just now. So this is a CT scan, and patient already have the tracheostomy to secure the airway. Can you describe about the CT?
Okay.
I starting from the nasopharynx. I scrolling down.
Okay, CT scan shows irregular, ill-defined collection at the retropharyngeal area with very severe narrowing of the airway. And there's evidence of presence of tracheostomy as well.
Yes.
In the superior mediastinum, I think the collection extends from the region of the floor of the mouth down to the I don't see. I think the upper chest is showing some consolidation with with cavitation, which may represent septic emboli in the lungs. Assessing the bilateral IJV, there is compression onto the left IJV, but it's still opacified.
Yes.
So overall features shows an extensive retropharyngeal abscess with sorry, it's too fast. I can't see. I think there's extension anteriorly along the thyroid or hyoid bone. Yeah, and also yeah, there's also extension anteriorly along the thyroid cartilage, and there's presence of septic emboli in the lungs.
Yes. So you are right. They are quite extensive retropharyngeal and also parapharyngeal, also involving
Oh,
the,
yes.
the oropharyngeal mucosa space, the peritonsillar region. So for this, because you're seeing a cavity, you're always thinking of septic emboli, and it's good that you assess both internal jugular vein. Any neck infection always see the airway and also blood vessel. These are the two important things in your report. And you can clearly see the airway is completely occluded for the oropharyngeal airway. Luckily, the patient already have the structural airway tracheostomy. And but this case is proven to be tuberculosis, just something you need to know. Sometimes TB can have abscess in the head and neck. So can I have the next participant to try this case? Thank you, Mehdi. This is a sore throat, right sided neck swelling for 3 days for 50 years old lady. Anyone want to volunteer? It's very straightforward. Session. Anyone can try. No one. Can I have Lao Zihao? This is no one want to volunteer. I just say this is a case of acute right tonsillitis. No? As you can see, the typical tiger stripe appearance on the right side, but you don't see any ring enhancing collection to suggest abscess. Okay. Anyone trying to do a aphasia 2B? Can you volunteer? If not, I just end the presentation.
Morning, Doctor. I'll try.
Morning.
Really here.
Yes.
So this is a frontal chest radiograph of a skeletally mature patient. I can see that the trachea is deviated to the right with narrowing seen at the proximal trachea. There's also air locules seen within the subcutaneous tissue on the left side of neck. In this patient, the lungs appear to be clear. There is some mediastinal widening as well. I would be in this patient, I would be concerned about deep neck space abscess infection with necrotizing component and mediastinal spread. I would suggest a further evaluation with CT, contrasted CT from the neck till the upper thorax.
Okay. So you identify the multiple area of subcutaneous emphysema. So this is a CT scan for the patient who have the chest radiograph performed. I just scroll slowly from up to bottom.
Okay. So there appears to be a large air-containing collection seen at the left side of the neck that is causing tracheal deviation and effacement of the, I think that was the oropharyngeal space, or oropharynx. The ipsilateral vessels, IJV and CCA are not well seen. I would suspect thrombosis of, especially of the IJV in this case of infection. Going inferiorly, there does not appear to be any extension into the mediastinal space.
Mhm.
So lung window, there is some cavitation seen at the right lung apex at no fluid level within.
I think it's a bronchiectasis.
Okay.
So overall finding, what is the diagnosis?
So overall finding, I think this is left neck abscess with secondary to gas forming organisms that is causing severe airway compromise and vascular thrombosis.
Okay. So this is a case of necrotizing fasciitis of the neck. Whenever you see an air pocket, always raise the suspicion of the necrotizing, which is an emergency for the ENT surgeon. And you can see the left internal jugular vein is thrombophlebitis with significant airway displacement, where you also can see the airway is displaced to the right from the chest radiograph. And this patient is a newly diagnosed diabetes. Okay. And okay. So the teaching point for this case is how you differentiate the necrotizing fasciitis from the simple neck abscess. There are a few points you need to take note is the necrotizing fasciitis usually won't show the typical ring enhancement that you see in abscess. And the necrotizing fasciitis usually have a lot of air locules, and they will extend to different facial planes of deep neck spaces. Usually abscess will confine in one space. Okay. And also necrotizing fasciitis will have bizarre shape that you can see in just now the case, the shape of the collection is very weird. Usually abscess will be rounded and well-defined or multiloculated collection. And for necrotizing fasciitis, will involve multiple neck compartments. And abscess usually confined to one compartment like retropharyngeal abscess. So by notice all these points, you can differentiate between the necrotizing fasciitis because not always, necrotizing fasciitis will have air locules. Okay. Good. Okay. Thank you. And I think these are all the cases I need to show. There are other cases just to show you some infection of the cyanidinitis. And Dr. Hafiz want me to apology to all of you because his battery is really, he cannot find his charger, and sorry for the technical error. So I hope that all of you can find some usefulness from our lectures today and will help in your daily work. And thank you for all your time, attention, and time.